Tribal Consultation Informational Webinar, National COVID Cohort Collaborative, N3C.
Hello, and thank you for tuning in. My name is Joni Rutter. I'm the Acting Director for the National Center for Advancing Translational Sciences, or NCATS. We're one of the 27 different institutes and centers at the National Institutes of Health, or NIH. And for this informational webinar, I will describe the National COVID Cohort Collaborative, or N3C. It's a program to harmonize electronic health records from across the nation into a secure data platform available for COVID-19 research. And I'm going to address three major topics today. The first is why N3C was created, as well as our reasons for seeking tribal consultation at this time. The second is what the resource is in more detail, including how we are protecting privacy, security, and confidentiality of EHR data. And then third, how the resource is being used, as well as how it could be used by communities, such as tribal communities, to answer questions about COVID-19. We've been working with the Tribal Health Research Office, or THRO, with Dave Wilson at the NIH for over a year now. And we've also met with tribal epidemiology centers and other NIH experts to engage in discussions about the project. And most recently, we've sent a Dear Tribal Leader letter and a framing letter to tribal nations to invite stakeholders to a consultation on N3C. And the purpose of this webinar is to supplement that information with a deeper understanding of N3C and to explain why we're seeking consultation. And also, as I'll describe in more detail, we do get tribal data with N3C. It's essentially categorized, or it is categorized, as AIAN under the race tables provided by the data contributors. And so we've worked with Dave Wilson and the THRO office to determine appropriate measures for handling the data until a consultation can be held. And so until such time, NCATS has temporarily obscured AIAN data while awaiting that tribal consultation. And data are available in total counts of patient numbers to reflect the accuracy of the numbers of patients within N3C. However, the AIAN data are not revealed when searching by race or ethnicity or by zip codes that may infer AIAN location. So these measures are temporary until NCATS can seek input from the tribal leaders before making that AIAN data available at this level for COVID-19 research. And until then, we'd like to just make sure that we can understand a path forward to ensure proper tribal sovereignty of the data. NCATS would like to discuss how we can work with tribal communities on an ongoing basis to consider a path forward for using these data for public health research on COVID-19 and to ensure that the policies and the governance to these data are appropriate. And finally, our ultimate goal is to begin to have a dialogue and a better understanding of tribal leaders' perspectives on benefits and risks of the N3C resource. We really want to consider how N3C can directly benefit tribal communities, as well as consider the individual and community privacy concerns associated with making certain data available for COVID-19 research. Now, as the youngest center at the NIH, you may not be familiar with NCATS, so I want to give you just a brief overview of who we are and what we do. NCATS was created about 10 years ago to advance the science of translation, which is the process of turning observations into interventions to improve health. And every problem we take on addresses a significant bottleneck to research, from the lab bench to public health practices. So we study these issues as a science to make research much more streamlined and predictive, and ultimately to bring more treatments to all people more quickly. At the start of COVID-19 pandemic, there were so many questions that emerged with very few answers. What were the hallmark symptoms of the new disease? Who was most vulnerable to COVID-19? How was the disease spreading? And what treatments seemed to be most effective? Well, the research communities needed large amounts of data in one place where it could be studied to answer some of these questions. And NCATS and our partners in the research community feverishly worked to leverage an existing effort to harmonize health information across different health systems so that they could be used to begin answering questions about COVID-19. And even today, we're not out of the woods. The emerging variants, for example, such as Delta and Omicron, reaffirm the need for clinical data to inform our understanding of this evolving virus and its effect on public health. So today I'm going to be referencing the use of data that come from electronic health records, or EHRs, Essentially, EHRs are digital versions of a patient's paper charts. They are a rich resource of clinical data, including an individual's medical history, diagnoses, billing data, patient demographics, vital signs, medications, immunizations, allergies, radiologies, and lab results, for example. And this information could be extremely valuable to bridge the gap between research and then clinical care, and then to enhance that research in clinical settings.
Slide title, Translational Research Need, Making EHRs Interoperable and Accessible for Research.
Now, in the United States, there's no standard way to collect electronic health record data, and there's no standard process for using EHR data for research. Therefore, data are in different formats, shown here on the bottom right-hand side of the slide. And because they're in different formats and different institutions have different ways of harboring those data, they're also siloed, shown here on the left-hand side of the graphic here. So making sense of the data on a large cross-organizational scale is extremely challenging, and it requires many people with specialized expertise to address this challenge. Now, over the past 5 years, NCATS has supported research to address these operational issues and to establish the computing infrastructure to enable this work. And that's how we came up with the National COVID Cohort Collaborative, or N3C.
Slide includes the words integrate, harmonize, accessible, longitudinal, COVID-19 research, improve patient care.
So with the urgency of the pandemic driving us, we created N3C, and it's a collaboration between several partners that contribute to and maintain the use of this real-world data resource about COVID-19. And due to the urgent need to quickly obtain clinical information about COVID-19, NCATS received a waiver of consent from its Institutional Review Board, or IRB, for N3C to be used specifically for COVID-19 research. And the IRB determined at the time that the research involves no more than minimal risk to subjects. The research couldn't be carried out practicably without the waiver, and the waiver would not adversely affect the rights or welfare of the subjects. And where appropriate, the subjects would be provided with additional information about the participation. So those are the key criteria for receiving a waiver of consent. Although the data in N3C are not consented, the data can be used through a restricted access model that isn't readily used to identify individuals. We make sure that individuals can't be actually identified. And the N3C is systematically collecting data derived from EHRs, harmonizing these data, and making them accessible within the N3C data enclave. This data is highly valuable, and therefore it cannot leave the enclave. We want to make sure that it is secure and centralized as a resource, and that exploration of the platform is available for collaborative research. This allows us to have that rapid collection of clinical data from the EHRs, from hospitals and healthcare plans during the pandemic, and it contributes to an understanding of COVID-19 itself. It contributes to the design of clinical studies and clinical trials, and it facilitates the identification of possible effective treatments that could be useful. And it can also help potentially inform clinical care decisions. And so the goal is to collect and harmonize enough of this clinical data on a frequent basis from COVID-19 tested patients and matched controls, or to support data analytics and statistics that require a large amount of data. Importantly, the data are longitudinal. So with new data flowing in from health sites about every 30 days. And so you can imagine that this is extremely helpful for studying the progression of the pandemic, including the entrance of those viral variants that I mentioned, Delta, Omicron, and so on. And it's also really helpful to be thinking about and studying the effects of long COVID. The N3C is also a very large data partnership. Data contributors are institutions supported through NCATS, through the Clinical and Translational Science Awards Program, or CTSA, as well as the National Institute on General Medical Sciences, or NIGMS. They support the Institutional Development Award Networks for the Clinical and Translational Research, or the IDEA CTR sites, and they transfer data to N3C as well. The National Center for Data to Health, or CD2H, guides the collaborative science environment in the N3C Enclave and also serves as the CTSA program's informatics coordinating center across the board. In addition, N3C is a centralized platform and provides the overall stewardship, and that's done through NCATS. The partnership expands even further than this with additional collaborators such as OCHAN. And this is a national nonprofit health IT organization working to improve health equity. We're also working with the NIH Office of Data Science Strategy, the National Cancer Institute, the National Institute of Biomedical Imaging and Bioengineering, the Food and Drug Administration, the Office of the National Coordinator for Health Information Technology, or ONC, and the Department of Health and Human Services. We're also working with the Biomedical Advanced Research and Development Authority, or BARDA, also at EHRS, and many other teams have been really critical to making this part a success. And together, the team is working collaboratively to create and operationalize a state-of-the-art analytics platform to enable novel analyses to address COVID-19. And this is helping us speed up scientific discovery and hopefully save lives.
Slide title: NIH Clinical Research Networks and their partners, leveraging real-world EHR data to research COVID-19. Slide includes a map of the United States with icons showing the location of sites contributing data to the N3C.
This work could not have been possible without the CTSA program. And when we first embarked on this effort in response to COVID-19, we started with about 7 different sites and just to see how it worked. And once NCATS finalized the data transfer agreements, we had 5 sites sign up overnight. And then over time, we talked with the National Institute of General Medical Sciences at the IDEA states to bring in COVID relevant data from areas that cover medically underserved populations. And the CTSA and CTR supported institutions collectively cover about 250 million lives. And so that's a significant number of records that could potentially really help us understand these questions related to COVID-19. So as of now, we have 67 sites contributing to this resource. Right now, we have about 9.5 million records within the data enclave, with 3.3 million of those reflecting COVID positive records. And we have a total of about 10.6 billion rows of data that these reference in that enclave. And so you can imagine that this amount of information is extraordinarily valuable for answering these types of questions.
Additional N3C data enclave statistics from December 2nd, 2021. 957.2 million clinical observations, 5.1 billion lab results, 1.6 billion medication records, 511.9 million procedures, and 506.5 million visits.
So N3C has very good coverage across the country. And at the bottom of the screen, you can see a live dashboard that is regularly updated with information about the data platform. So please feel free to take a look.
The URL to access the dashboard is https://covid.cd2h.org/dashboard/.
So we centralized COVID-related data into the N3C platform because we thought that there was an incredible amount of value for the community to address these questions. There are questions that can be answered at the local level, meaning each organization with EHRs can do some valuable research. However, by harmonizing the records across organizations and systems, a broader understanding of the pandemic and its impact could be understood. So the opportunity to study such topics like social determinants of health and how COVID affects different groups is now really possible.
Questions that can be answered with local information are: is drug X beneficial to COVID-19 patients? Does disease Y impair course? Does an income of greater than $50,000 per year improve outcomes? Additional questions that can be answered with nationwide information, for example, N3C, are: what drugs help COVID-19 patients and which hinder? What diagnoses impact outcome? What social determinants impact course and outcome?
In addition, by creating one harmonized data platform that includes a diverse set of data from across the United States, there's more opportunity to work with a broader sample of the US population, thereby enhancing that generalizability of the data itself.
Slide title: 4 Pillars of Data Protection: Regulatory and Privacy, Privacy Measures, Security Testing and Monitoring, Researcher Responsibilities.
NCATS takes its role as a steward of the data very seriously, and so we've taken a comprehensive approach to protect the data, balanced really against the need to make the data quickly available for research on COVID-19. And so I just wanted to highlight a few of these examples of how we're doing that. In terms of regulatory and privacy, NCATS has taken the responsibility of ensuring that the N3C follows federal regulations and NIH policies to address patient privacy and human subjects research. There's the Health Insurance Portability and Accountability Act, or HIPAA. There's the HIPAA privacy rule that balances keeping health information confidential with other social benefits, including healthcare research. And HIPAA defined limited data set is protected health information that excludes 16 different identifiers and may be used for purposes of research, public health, or healthcare operations without obtaining an individual's authorization or a waiver for its use.
Additional regulatory and policy measures listed are NIH, IRB oversight and waiver consent for COVID-19 related research only, no genomic data, and no emergency public health authorities were used to obtain the data under these conditions.
In terms of privacy measures, there's a certificate of confidentiality that is protecting N3C. It protects the privacy of individuals and their data by prohibiting disclosure of identifiable or sensitive research information to anyone connected to the research. And as a rule, any zip code with less than 20,000 people are also obscured to protect privacy. And as I'll get into on the next slide, there's additional privacy measures that have been applied to the AI-AN data until we could do this consultation with tribal nations. And that allows us to understand how best to move forward with handling that type of information. Because we do get AI-AN data with the data information that's transferred to the N3C repository.
Additional privacy measures listed are data stays within the enclave, no download or capture of raw data, privacy impact assessment, and review of project requests by Data Access Committee.
In terms of security measures, N3C is taking multiple precautions for security to keep these data safe within its protected cloud infrastructure, including the utilization of a cloud environment that meets the most stringent US government security and compliance requirements. It's also managed by NCATS. There's a robust end-to-end encryption in all data that's trafficked to NCATS. There's also a comprehensive auditing of all data processing and access within the cloud platform. And this also includes researcher responsibilities. For example, the N3C research community drives the behaviors. And so this is really community driven. And the community, the N3C community, has developed a code of conduct referenced in the data use agreement that has engendered collaboration and transparency. And this is really a big part of N3C's success. It's very different than approaches that have been taken before, but this is really enabling a team science kind of approach for this particular research enclave.
Additional security testing and monitoring measures listed are scheduled penetration testing and active monitoring and logging by NIH and HHS.
All researchers and their institutions sign a data use agreement and adhere to the N3C specific code of conduct. And this requires that they affirm that they will not re-identify patients in this resource and agree to all of the rules of engagement. We also have community guiding principles to set the stage for a cooperative, a collegial, a respectful research environment.
Additional research responsibilities listed are required NIH IT security training and required human subjects protections training. Slide title: Additional privacy measures for American Indian Alaska Native data while we seek consultation. 2 tables depict sample American Indian Alaska Native records before and after data are obscured in the N3C cleaning and harmonization pipeline.
Now, based on initial discussions with the Throw office, NCATS has decided at the outset to temporarily obscure AI/AN information, as I mentioned before, until we could have a tribal consultation. And although N3C is receiving the demographic data on patients from the academic or community medical centers that are contributing data to the platform, including AI/AN as racial indications, our data pipeline is set up to default the AI/AN identifiers to the other category in that same racial data table, so that they're obscured to really protect that privacy. This allows us to maintain the integrity of the data while protecting the privacy of the AI/AN data until we could understand how to ensure that tribal sovereignty of the data. And so our hope is to establish a way for all groups to be able to access and use the data for these important research purposes. Now, we recognize that AI/AN identifier status is not the same as tribal affiliation. And so to be clear, the Indian Health Service is not one of our current contributing sites, and N3C does not include tribal affiliation information. To ensure that tribal affiliation cannot be inferred through the zip codes that we receive, we opted to also obscure those zip codes when they overlap with tribal land or with high proportion of tribal affiliated individuals. And given that these data are currently unavailable to researchers, both general researchers and those from tribal communities, we're seeking consultation to inform tribes of this resource to seek input on whether or how these data could be made most useful for COVID-19 research, including support of tribal health research on COVID-19. It's also important to mention that demographic data from the health setting is generally either self-identified or it's provider identified information. And those aren't necessarily consistent or even accurate. So this applies across all racial and ethnic categories. The categories are analogous to the OMB race and ethnicity data, and rather than perhaps more granular population classification methods. And lastly, there's no connection to the patients directly. This is an existing data enclave. So these data are coming, the data that are sent to us have already been in other data warehouses, and so they already exist. So since it's existing data coming from the clinical domain, there's not an anticipation that more pre-engaged or community-based participatory research is going to be done, at least at this time. And if it is done in the future, that would be something that we would want to consult on again going forward. But at this time, that is not part of the plan. It's just about really accessing and using the data that's within the N3C enclave.
Slide title: Prioritizing Tribal Perspectives. Slide design includes the words and phrases solidarity, mitigate harms, maximize benefits, inclusion, education and opportunities, communication. NCATS activities: working with Throw, monthly meetings since September 2020, conversations with external experts, Johns Hopkins Center for American Indian Health, August 2020, South Central Foundation, September 2020, Tribal Epidemiology Center Directors, September and November 2020, learning from NIH COVID-19 Tribal Consultations, May 2020, NIH Tribal Consultation on COVID-19 Research, July 2021, NIH Tribal Consultation on Rapid Acceleration of Diagnostics, RADx Tribal Data Repository, April 2019, NIH Tribal Consultation on Draft Policy for Data Management and Sharing.
Now, as mentioned as just mentioned, since September of 2020, NCATS has been working with the Throw office on tribal considerations for research in N3C and preparation for this tribal consultation. We've also had several conversations with experts, both externally and within the agency, again, to make every effort to avoid any missteps and really understand lessons learned from others that have gone before to how we can best prepare for this consultation that we can have. And additionally, we've been paying close attention to other of these NIH COVID-19 consultations, for example, and we've reviewed the existing NIH tribal consultation reports from the past few years to ensure that we're learning from those, from all earlier conversations on similar topics and incorporate those prior concerns and questions into our thinking, though recognizing though that this is a different project. And so we want to make sure that we are also open to other ideas as well as we go through the consultation process.
Slide title: What research does N3C enable?
And again, the pandemic raised many difficult questions, like which drugs are most likely to benefit a given patient, what treatments, risk factors, and social determinants of health, for example, impact disease course and outcome. How do we develop, adopt, and deploy the clinical decision support to keep up with the dynamic pandemic? And N3C can be used to study these issues, and increasingly relevant is studying this idea of long COVID in addition to the variant waves that we've been seeing. And so this resource is being used to determine the impacts of the social determinants of health on COVID-19 outcomes. It's being explored for evidence to support the effectiveness of using existing drugs and how drugs are being used in our population to combat COVID-19. And the N3C can be used to study how COVID changes in our population geographically and over time, including how the distinct surges and variants might be different from one another. And then, of course, thinking more recently, the N3C is obtaining information about vaccination status, which is another key data point that we're including in the enclave.
Slide title: N3C is contributing to our understanding of COVID-19. A list of publication topics: description of N3C, health equity, diabetes, cancer, machine learning, COVID meds. A list of preprint topics: HIV COVID risk, rural population mortality rates, long COVID, others.
We've rapidly developed and we're quickly delivering on N3C to contribute to our understanding of COVID-19. The NIGMS's IDEA CTR investigators, for example, demonstrated a 40% increase in mortality for rural populations compared to urban ones. It's a striking and important finding to really help us address maybe future needs, immediate future needs for those types of populations in those rural communities. In another publication on HIV, individuals with immune dysfunction have a greater risk of severe COVID-19 outcomes. And more advanced HIV disease, for example, people who may have greater immunosuppression or HIV viremia were also associated with higher odds of severe COVID-19 outcomes. So again, understanding the specific needs of individuals and how COVID-19 might affect them is important knowledge to be able to better help our care providers and how to get the best treatment for them. And then COVID-19 was twice as likely to be fatal for people with chronic obstructive pulmonary disease or COPD than those without COPD. So again, just more information about how people with different comorbid health issues are being affected by COVID-19. So these are important information that we're starting to gather.
Slide title: N3C Registration Training.
Training is also an important element of N3C, and so I wanted to just briefly mention that there are office hours for N3C users, as well as training videos and tutorials to assist individuals working in the N3C data platform. It's another area where we want to understand and meet the needs of the communities using these types of data.
The URL to the training videos is https://covid.cd2h.org/tutorials. Training office hours are Tuesdays and Thursdays at 10 to 11 a.m. Pacific Time and 1 to 2 p.m. Eastern Time. The URL to office hours is https://covid.cd2h.org/help_desk. Slide title: Seeking Input from Tribal Nations.
So to basically sum up, I guess, in a way, N3C is receiving AIAN data, and we want to make sure that we're understanding how best to incorporate these data into the research enclave. These data are either self-identified or provider identified, and also they have zip codes of those patients. And so again, to ensure that we don't overstep by providing researchers with access to this information until a consultation can be done, we've obscured the AI and demographic data and the zip code data within the other category for the AI and demographic data, and by removing the zip codes for the areas which have been identified by our NIH colleagues to overlap with tribal lands. So before we finish, I just wanted to outline some ideas that we're seeking input on to determine a good path forward for how AI and data in N3C could be made available for COVID-19 research. So here are some ideas for how these data could be managed by N3C, and we're very much open to any additional ideas and your opinions on which path might be best for managing access to these sorts of data. And so we wanted to give you this sort of preview of what that might be to help kind of help you think about some of those ideas and what they might look like. As an example, though, one of the ideas we would just continue to do what we're doing. The data from the AI and identified individuals could continue to be obscured in the way that we've done so, as I've explained in this webinar. And if we did that, then the demographics and the zip codes would remain unavailable for research purposes. The second idea is that we could create a separate section of the enclave. It's sort of like an enclave within the enclave for AI and specific data, and then the data would also remain available in the main enclave as it was before, basically simply obscured. But if we created an enclave within the enclave, there would be a second layer of approvals that would be needed, and that we could get those through a process that would include perhaps tribal representatives looking over the requests, for example, and that would be available for researchers who want to use the additional information for their research questions if they wanted to include specific information about AI and related data. And if we did this, then researchers with AI and data approvals would be able to access that unobscured data. And we would want to make sure that we establish this appropriately so that tribal representatives would determine the process and the level of that involvement, however that would be deemed most appropriate. And then the third is that we could make AI and data available to the enclave in the same as other demographic categories. And if we were to do this, then there would be visibility by all researchers in the enclave for AI and data. This might have the greatest impact because it would be used with all other types of research, but it may not be the most ideal. And so we want to make sure that these different ideas might be most appropriate. And they're also not mutually exclusive. We can consider how to perhaps beta test some of these or work with you on other ideas on how to establish what paths might be best to move forward.
Slide title, Seeking Input, Pre-Consultation Questions.
So NCATS, we're aware of the importance of data sovereignty, and we want to know how to ensure that this is the case for N3C. And it's so important to have this electronic health record data available, but we also want to make sure that we're responsible in doing so, and specifically setting this up for COVID-19 research for all. We believe there are ways that AI and data in N3C could be helpful for both broad public health research as well as for answering questions that have the potential to directly provide knowledge useful for tribal nations and their community responses to COVID-19, such as the study of long COVID, for example, or about social determinants of health and COVID-19 outcomes. And so the questions that we have for tribal leaders coming to the consultation are the following. Should AI and data be unobscured and made available for COVID-19 research? And then if so, how would tribal communities want to be involved in that governance and in that access and use? And are any of these ideas on those earlier slides, are they appealing or can we work with some of those? The other question is, what additional steps would the N3C need to make to consider making the data available? And what are your suggestions for ensuring that there is an ongoing partnership with the tribal communities and researchers, irrespective of how N3C might proceed? We have, for example, domain task teams within the N3C Data Enclave, and these are made up by community researchers. And so we would welcome researchers from tribal communities, for example, to participate in that or contribute to that kind of an effort. And then thirdly, if tribal communities want to use the resource, what outreach is needed to engage that tribal research? So that's sort of where we are now. And I just wanted to say thank you so much for viewing the webinar today. After we've worked with the Tribal Research Health Office for a while now, we hope that this is the start of a productive and ongoing engagement with tribal nations. And I very much look forward to the time when we can meet for a consultation. And I believe that's going to be in the beginning of the new year.
NCATS tagline: collaborate, innovate, accelerate, and NCATS social media handles.
Thank you again, and I look forward to seeing you or hearing from you.
For more information about N3C, visit URL https://ncats.nih.gov/N3C.